thought leaders and voices. We got Camile McWhirtter, Omega Healthcare, with us today on the show.
Yeah,
Thanks for having me. I'm
welcome.
excited.
Well, we're excited.
Absolutely.
What are you thinking of
Great.
ViVE so far?
It's great. I love the energy. Of course, there's so many new technologies. I can't keep everything straight. So that's what I've been trying to do is, just watch some demos, listen to these sessions. Phenomenal.
Yeah, it is hard.
Is this your first ViVE?
Not my first.
Okay.
Not my first. But I've been to all the shows, health,
Yeah.
hymns.
circuit.
Yeah, I mean, I do the circuit. Yeah, no worries. So I knew what to expect. I always love to see all the new companies and all the new technologies.
Yeah,
We got to keep ourselves,
up to date. I know.
educated. Up to date.
And we bonded over sneaks already this morning, which should pretty much be
So excited.
deemed a technology
They
in my
really should.
opinion.
I mean, I
so
think every woman on the show floor is looking at feet or they have them on their feet.
I can't even wait. These
Yeah.
sneaks are sitting on my doorstep right now.
Yes.
Didn't make it in time.
Yeah.
For you folks out there,
Yeah.
understand
I'll
that
be
our
wearing
show
my
is not
heels.
just about healthcare, because your feet are part of your health.
It is very important.
This is very important to our industry.
It's so important, Maureen.
I know. We'll continue the conversation, but Sarah Blakely, feel free to reach out. We would be happy to work with you.
That's sneaks.
Yeah,
SNEEX. Camile McWhirtter from Omega Healthcare. Just
Oh my gosh, I love it. I love
We're
it.
not shamelessly plugging or anything on this show.
Oh, we were. That was shameless. Yeah.
please
yeah.
reach out to Maureen.
Yeah.
What have you seen on the floor that has just intrigued you this year?
Yeah, I mean, of course, there's all these AI technologies, and really the interoperability interests me the most, because whether this is controversial or not, I'm going to
please.
say it.
Yes,
I want
yes.
to give you controversial, because these health systems that are sometimes forced into plugging new pieces of technology
Yeah.
to solve problems are just putting themselves deeper and deeper in trouble, right?
Right.
Would you agree? I mean,
100% agree.
Yeah.
so that's sort of my frustration is, okay, we've got all these amazing technologies to connect the dots,
Right.
to stitch them together properly, but it's hard and it's expensive and sometimes disruptive, but at some point they have to do it.
Right.
Yeah.
You can't, there's so many beautiful, wonderful, shiny objects down there, but it's not going to work if you keep plugging holes.
100%.
Yes. It's almost like, and I always go back, I'm a nurse by background, so
Yes.
I always go back to what does that look like kind of from my angle. And it's you get prescribed a medication because you've got a symptom, and then that causes another symptom. So they give you another pill
Oh my God.
in order to avoid that symptom. And so we're doing the exact same thing in healthcare from a technology perspective.
Absolutely. And I'm glad you mentioned pharmacy too, because I think that was one of your questions. I was going to go down that road where my favorite is, it's another controversial topic.
This
Okay.
is what the show is for.
I'm sorry, but the EHR centered apps sometimes in some spaces, in some lights, are not the best of the best. And there is wonderful, excellent technologies downstairs
Yeah.
that we can plug in and really, expand. But it has to be interoperable. I mean, we have to stitch them together.
Right.
But, to health systems, you don't always have to go with the EHR centered products.
Yeah.
But let's talk about proper implementation. Let's talk about upgrading for your patients, patient satisfaction, pharmacy. I mean, it needs to be discussed, and sometimes you gotta jump in.
You're not in the vein of one throat to choke, because you believe that
No.
if there's a need out there, let's go facilitate that need for patient care now, then wait for a roadmap.
Yes.
May never come to fruition.
Correct.
Right.
We can't rely on that.
Right.
And, there are phenomenal companies out there that can help you build it. And Omega doesn't help build. So this is not a play or a plug for Omega at all. But there are companies out there that can stitch these pieces together. It may be a short project. It may be not very costly. And maybe that's all it takes. It's
Yeah.
just a little teeny, just a small little project, not a pilot. I'm talking about stitching together the right pieces, the right tools together to make it seamless.
Yeah. So taking really one bite of the apple at a time.
Yeah.
I think it's almost a sense of overwhelm that people feel of, I don't even know where to start. And so therefore, maybe if I just don't acknowledge it, it'll either find a way that it's going to work out
or it's good enough.
Right. Exactly.
Yeah.
And then
Good
they
enough
end up with
doesn't work.
all of these apps that don't necessarily have any validity in the day-to-day world, but they're sitting there unused, or there's pieces and parts of technology that they've got that they've never fully implemented. So tell me more though about what Omega Healthcare is and does.
Yeah.
And
Absolutely. So Omega Healthcare is primarily an RCM company, so revenue cycle management.
Awesome.
Best in class, phenomenal. They just won that just a few weeks ago.
That's so cool.
So that's great. Our division focuses on quality data for clinical trials.
Okay.
So you talk about real world data.
Yeah.
You know, again, down on the floor, there's tons of phenomenal tools out there.
Yeah.
But what we are doing is we're utilizing our own AI but human in the loop,
Yeah.
of course, to maintain quality data. So our team is a team of physicians, dentists, pharmacists, oncology specialists that take that data, maintain quality at a 95% plus accuracy rating, so that it maintains that FDA grade quality for clinical trials, or abstracts, treatments, whatever that may be. So, you know, and we maintain cancer registries, stroke registries, just the whole gamut. The whole
Beautiful though.
Who's your typical customer? Who's coming to Omega?
Yeah, so cancer institutes, chief data science officers, CIOs, CMIOs, researchers, PIs that are running these trials. Because what happens is we have so much data out there.
Yeah. Yes.
But it needs to be curated. It needs to be cleaned up. And if we can increase the number of trials for patients.
Yeah.
There is a huge, shortage, I would say, of patients who are in underserved areas or community health, rural health. That's where most care is given.
That's right.
But these patients for clinical trials are typically coming from, the academic medical centers or the large cities and health systems. And I feel like we just keep using the same patients over and over again.
Yes.
But, it really doesn't make sense. And really, now I'll talk about women's health here for a second, Maureen, because that's another very, very big focus of mine and others in the industry, because I don't know if you know it, but even just 10 years ago was when the NIH actually, I had to check the date.
Okay.
Yeah.
So that's why I have my little cheat sheet here.
That's okay. I love it.
But the NIH established the SABV policy, which is sex as a biological variable, just 10 years ago.
Okay.
Meaning that they have to have clinical trials that both men and women. I mean, it was in 1986 that they said, well, it's okay. We would like to include women. And that was the ruling.
Yeah.
It's okay. We're encouraging the inclusion of women.
Oh, wow.
Can you believe
So we really don't want to collect data until after, what happened before 1986?
They
just excluded women altogether?
Yes.
Yeah.
Yes. Yes. And then what's sad about that really is you think that you're going to react the same way to a medication as what Camille or I would.
Right.
No.
Right.
You're exactly right.
Yes.
And
yes.
reaching for some more stats, because that's another part of the problem is, you've got Alzheimer's, for example, which hits more women than men.
Right.
But there's more men in trials.
Right.
Right.
So why does that make sense?
Right.
About that even in African American women and
Absolutely.
Yes.
control,
Oh
childbirth.
my gosh, Mike.
Yeah.
All of these parameters come into play, but they're negated or not
Absolutely.
even part of the test, right?
Absolutely.
And so when you start looking at that across the chasm of care,
So frustrating.
a lot of dips in data, a lot of dips.
Absolutely. It doesn't make sense. I mean, if you both had a specific coronary event or some kind of diagnosis, it does not make sense for all of us to have the same exact medicine if it really wasn't tested on that.
Yeah.
on that particular.
She's trying to give me
Yeah.
a heart attack a couple of times.
Well, yeah, you know, that's, I figured that's why I mentioned that. So,
Thank you.
yeah.
So,
And okay.
20% of coronary events occur in women.
Yes.
It's
And it presents
with
completely different.
known risk
Yeah.
factors at all.
Yeah.
Exactly.
Yeah.
And so twice as many women as men suffer from depression.
okay.
And that's the leading cause of disability in women. But again, the studies
Yeah.
don't match.
Right.
Exactly.
Right.
Women make up 46% of lung cancer deaths. Did you know that?
I did.
6%.
But only 15% of the lung cancer budget went to women-focused research
Yeah.
Let me
in
ask
that
you
area.
on
Yeah.
that one topic alone. So
Yeah.
Omega would take this data, present it. 46%. That's a large number.
It's a
right?
huge number.
And do you even backtrack to, is that from women that are smokers or women that are getting secondhand smoke
We
or
take
working in? Do you
all
do
of that data.
All of it.
So what we would do is the physician would come to us and say, hey, I need to do a lung cancer trial.
Okay.
I have this data dictionary that defines all of the pieces and parts in my EHR. Here are all the sources. I need you to curate a trial, or I'm sorry, curate the data
Yeah.
for, 300 patients out of the data I have right here, clean it up, make it usable. And I also want this comorbidity diagnosis and this, this is the project model.
Yeah.
All of those pieces and parts from these researchers, we take that,
Okay.
do some manual curation, because the work that these physicians and pharmacists are doing, it's very highly clinical.
Yes.
It's complex. I
Yes.
mean,
Yes.
know from
Yes.
Right.
both of you
Yeah.
know it's very complex.
Mhm.
They need to do hit the 95% plus accuracy rating and keep it FDA grade
Right.
quality.
Mm. What gets you excited about the work that you do? Because I love the passion. I
Yes.
do. And whenever you talk about
Yeah.
rural
You
healthcare,
can
you
tell.
talk about
You can
women's
tell.
healthcare,
I
or
think
you
you
talk
already
about
know.
advancing care in general, I just light up. That is
Me
definitely
too.
within my wheelhouse. But what gets you excited?
Well, it's, think about all this data we have now. How about wearables?
Right.
Wearables, all
Right.
this wearable data, the rings, the remote therapy monitoring.
Yeah.
All of that data is kind of stuck out there.
Mm-hmm.
Our teams can go in and clean up, all of this. In fact, there was a cancer center. This is another passion of mine, but there's a cancer center that was 10 years behind on their documentation for their registries. We cleaned it up in 6 months.
Wow.
That's hard.
So now they can use that data to pull in some more patients for trials,
Right.
do better treatments.
Right.
So what I'm passionate about is that. I mean, hey, let's partner with Omega Healthcare.
Yeah.
Clean up this data so we can move forward, and maybe some women's health, and give me some perimenopause advice based on my Apple my watch and all the wearable data that I have.
I'm pretty sure we're gonna be doing a whole segment on perimenopause pretty soon here.
And
I mean,
by
it's
the way, let me tell you another stat, actually.
Yeah,
Well,
I love
it's
that.
it's not even a stat, but what I will say, my sister sent me this message this morning because I've been preaching
Yes.
Mhm.
Yes.
perimenopause route, and women should see a menopause specialist, not just a gynecologist.
Right.
Okay, this is more personal than perhaps
You know what? There's
needed to
nothing
be.
more personal than healthcare.
That's right.
Absolutely. But I will say the menopause doctors, and combined with new FDA regulations and recommendations, I should say,
Yeah.
now women are seeing an uptick physicians are seeing an uptick in prescriptions for the estrogen patch to help. And now there's a shortage. Now we've got drug shortage.
Now you finally figured the silver bullet kind of looked into the gun. Now you can't shoot any more bullets.
Yes. So now we have to go back to pharma, and say, can you help me boost up?
Yeah.
I think what's really remarkable about that, though, when you take a step back, it shows the advancement that we have made in progress towards women's health.
Right.
Now, what's sad is it also reflects that the production, they never anticipated us to ever have that.
Yeah.
And so it's great, and it's also a little sad.
Yeah. That's okay.
But, we'll
bounce
take the
back.
progress. We need to make the progress. And so I'm excited for you. And tell us a little bit about how we can
All of
find
us.
Omega Healthcare Are you here? Do you have
Yes.
a booth? What's going on?
So no booth, but
Okay.
we are having conversations all over the place. We're booked back to back. So
I love it.
But feel free to reach out to me on LinkedIn. So Camile McWhirtter, it's McWhirter. You can reach out to anybody on the Omega team.
Okay.
My boss and general manager, SVP Heather Gray, GREY, phenomenal resource, phenomenal mentor.
Love it.
Lots of women in our department. Just sorry, Mike, but
Okay. That's
No,
he would be outnumbered.
he's a good supporter of women, so we're thankful.
Of course,
Yes.
of course.
Yeah.
It's
but tell me where I got into the trash and sweep the floor.
Yeah.
no, I don't believe that. I know, but that's really. I would say my and sort of closing comment is really exactly that: is working together. We
Yeah.
all need to work together to fix and stitch these systems together. So
Yeah.
interoperability,
Uh-huh.
which
True.
Yes. She doesn't like that word.
I think it's dead.
yeah. Oh. But also really increase the ability for Omega Healthcare to come into these health systems,
Yeah.
and research organizations, help clean up some data. Let me do a quick project. And
Right.
Yes.
If you
Yeah.
want to do a pilot project, which
Right.
Yeah.
that's a whole other
Yeah. But you are
Turn,
making
but
those advancements.
let's get it done.
Yeah.
Move on.
Mhm.
Let's increase the number of clinical trials out there and keep advancing medicine.
Yes.
That sounds excellent.
Oh, I love
Camille,
it.
thank you so much for joining us on the show today.
This
We're
was
live
great.
we're live for everyone to see this today. So they're getting this straight to their living rooms, desks,
Yeah.
where they're sitting this morning. So
Yeah.
these are great topics. I mean, Omega's doing great work. They're making this data usable, something that's actually going to make changes in people's lives.
Yeah.
So we thank you for the hard work you're doing and your team's doing.
Yeah.
Thank you, Maureen.
Yeah.
Looking forward to seeing you down on the floor again and more
Yeah.
shows. Hopefully
Oh,
see you
yeah.
at the next one, right?
Sounds good.
Yeah.
Hymns leader,
Hymns.
so I'll be hosting at Hymns as well.
Oh, that sounds
Awesome. We'll see you there.
Yeah.
Yes.
Oh,
Sounds
Thanks
good.
for joining us.
Thanks,
Yes.
guys.
We're going to take your mic because we got somebody
Okay.
else coming to the show here real
You
soon.
got it.
yes.
And we will
Can you
talk
reach
to you
it?
on the floor in just a little while.
All right.
All
All right. Thank you,
Thank you.
Camille. Yes.
So we are back live here at HIMSS at ViVE 2026. I'm trying to get a week ahead of us, aren't we? Trying to get somewhere else?
Oh no, this is
no,
gonna be. It's all gonna go downhill from here.
Downhill from here. I'm trying to get a week ahead. We're here at ViVE 2026 with our live show. We've got guests coming to us all morning. Philip is coming to us next from 10.
Throwing things
We
in the
want to make
background.
sure that you're here streaming live with us to get this content. If you have questions for Camille, who's joined us here, please reach out to either us or find her at Omega Health.
Yeah. Yes.
Talk to you
Thank you,
soon.
Camille. Yes.
Have a good
Thank
one.
you. Thank you. Okay, I'm so excited about this though, Mike,
All right.
because we just talked about a couple of things. Yes.
Come on in.
That
Philip.
were just so impactful. I
Right.
love the idea that you can take all of this data and start to massage it and
Right.
actually get some use out of it. We just collected it for so many years, but we didn't necessarily know what we were going to do with it. So,
Right.
okay, let's
Amazing.
keep the
That's kind of our
conversation
pitch.
going.
All
Is that your pitch
Hey.
too?
So,
Isn't it like everyone's pitch these days?
Ah.
And then you add AI on it,
No.
and boom,
You got
the
it.
world is perfect.
Oh my gosh. Okay,
Great. See
now
you
I
next
can't
year.
wait. Yeah.
Philip,
Show's
thank you for
over.
joining us. Philip,
Yep.
let's talk to our audience here. Tell everybody who you are and where you're from today.
Okay, Philip, founder and CEO of Contact.io, came in from New York on a snowstorm.
Yeah.
Grew up in Germany, hence a bit of an accent.
I was going to say, you
That's
don't
a bit.
sound like a
That's a bit.
native New
You know,
York.
like my team at this point, I've been living here for a long time and
Uh-huh.
been to high school as well. Like people are saying, you should like go for like a media training. Like, no, we'll
Yeah.
keep that accent.
Keep that accent.
Yeah.
Because talking about stereotypes for one point, we are in the business of improving processes
Okay.
in healthcare, focusing on the non-clinical side of things. So I call it sometimes, internally boring stuff.
All
We
right.
do boring AI,
There you
but
go.
very important because our mission is to lower the cost structure because healthcare is too expensive, and especially when we go into the four walls of a hospital, there's a lot of waste, there's a lot of inefficiencies that all sit on the intersection of care operations or how care is being delivered and
Okay.
what resources are being needed. And our purpose is to come in and to help health systems do more with less. And we've proven that, some of the largest for-profits and non-for-profits in the country. And what's sort of unique, talking about data,
Yes.
is in a world where data is kind of guiding us and driving sort of the actions, we are a net new data creator.
Oh.
So we are on the intersection of, what is called the physical world and the digital world.
All right.
We are in the business of tracking every single thing that moves in a hospital, from the patient to equipment and assets,
Okay.
to how rooms are being utilized. So think of it this way: an Apple AirTag
Yes.
on every single piece of equipment, a small disposable biodegradable chip that you put on an existing patient wristband, and suddenly we understand the hospital as if it was digital.
Okay.
In an
You can
IoT, we call it a
see-
digital twin,
Yes.
and then we can start optimizing on top of that.
Okay.
Wow.
So
That's
never,
what we-
never lost, right? Basically for equipment and people.
There you go. And it's been an industry that has been around for like, I think, 25 years. And
Yeah.
it was previously called RTLS.
Yes, that's what I know it as.
And it's what I've tried to avoid for the first 5 minutes.
Yes.
Because RTLS stopped at visibility. Here's a map.
Yeah.
Now you can, who needs a map? No one needs a map.
Right.
What I need to know is, what can I do in the moment where things go wrong? In other words, what is the execution? What's the automations? What is, within the existing systems that I have?
Yeah.
Tell me what I should do differently. I don't need a dashboard. I don't need a map.
Right.
But if a patient is waiting to learn, let's create an alert and
Yeah.
notify,
Yeah.
somebody in charge that maybe we are entering into a problematic area here,
Right.
because if we're not intervening right now, patient will have to stay another day, which is going to become very costly.
Very
Tell me
costly.
about one of your successes in that area.
Um,
We talked about alerts for patients.
Yeah.
so
Being able to get into that area. What does that look like for Contact IO?
I mean, look, I think one of the most, I call it, most pragmatic and kind of grounded use cases
Yeah.
that like the audience kind of can understand sort of immediately is the use case of providing nurses with a device
All
that
right.
when they're in a duress situation, they can press the button
Yes.
Okay.
here,
Yes.
and the moment they press the button, somebody is able to locate them.
All right.
And there's an SLA between physical security and nursing, and within 90 seconds, security shows up.
All
And
right.
Yeah.
unfortunately, workplace violence is a real issue. And if you look
It
at,
is.
some of the public statements across some of the strikes that have been going on sort of with nursing in the country, safety is top of mind.
It
and
is. It is.
With hospitality and healthcare still being some of the two most dangerous professions
Yeah.
out there, raising sort of the awareness and providing simple solutions
Yeah.
that essentially provide kind of caregivers and patient-facing staff the ability to be seen
Yes.
in a moment of where they feel uncomfortable, need help,
Right.
is very, very simple. Yeah,
Yes.
and it's very powerful. And I think until today, we are probably the number one provider of these type of safety application at large to U.S. healthcare. We are, working with the leading for-profit and non-for-profit health systems
Right.
across the country on these initiatives, and that's something that makes the team very proud. And I think it's a very simple use case that explains
It is.
what we do, and now we can go into patients, and it gets much more operational, and,
Yes. But,
less emotional, but yeah.
We have to protect our caregivers.
Right.
That's always going to be paramount. We've seen this, and you're
And
so
no AI
right.
is going to help us either way or not. Like,
No,
you need
no.
to
Yeah, and
put people front and center.
what I love, though, about what you said, I'm going to back you up just a couple of statements because I can definitely appreciate that safety aspect. But you said something really interesting. You focused on the fact that it wasn't just a dashboard, that it wasn't just a map, but rather you're looking at it from the perspective, it sounds like, from a workflow, because you're looking at the movements that are happening. We did RTLS in our health system years ago, and I think in our mind's eye, we believed that we'd be able to figure out how often is that nurse going back and forth to something, and let's find a way to maybe move that whatever they're going for 10 steps closer. We never realized that.
Yeah, and
So is that what you're talking
I'm
about?
talking, and I'm even going
Okay.
a step further. Was a very smart COO of a 30 hospital health system
Yeah.
told me a couple of months ago, and it's kind of spot on, so I'm using that as an example. How we envision this is nobody should ever have access to a map, certainly not our caregivers and nurses.
Yeah.
Right.
Why? Because our job should be, based on the data and the algorithms that support the data, to always make sure that the right equipment is at the right place at the right time.
Yeah.
And the KPI, if you want an anti-KPI,
Yeah.
if somebody wants to look for something, we have failed. If somebody needs to log into a map or into Epic, it's a data point for we have failed because it should be there.
Yeah.
So why can't we think about supply chain if we stick in that universe of chemical engineering, which historically has been a supply-driven framework, right? Let's optimize within par levels here and there, and then every day at 6 p.m. somebody rounds and like fills stuff up.
How much stuff do we have?
Yeah.
Like, why don't we turn this upside down? We make it demand-driven. Like, what is the clinical demand tomorrow, today, right now? And because we can predict these things pretty kind of straightforward these days, let's inform that and then be, proactive around where things should be. Let's consolidate the tickets instead of, in this case, a human doing the job of planning the tickets and where should somebody go. We can have an agent doing that job. It will do a much better job, right? And it's the perfect example. We're now sort of leveraging the best sort of both worlds. Give me the recommendation of like what should be moved at which point, from where to where.
Yeah.
And then let's aggregate it in a task, make it more efficient, and distribute it to the closest clinical engineer, available that is then, executing that sort of job order.
Yeah.
Phenomenal. Yeah. And then the KPI needs to be nurses walk less. Nurses don't search for stuff, and every time there is something missing, we'll collect that data point probably through a phone call and not through a software interface.
That's the kind of.
So now change management is gone because who do you need to train? No one.
I love that.
Yeah.
But
No,
this
it's
is where
important. It's important.
like everything comes together, and yes, instead of
it took us the cloud. It took us now AI, and I'm like. I am the number one thing, which is phenomenal, I think, to all of us, especially us sort of working on the adjacent, maybe call it less obvious, less flashy sort of AI use cases. It's not ambient listening. It's not, I don't know, radiology. But everyone has now learned through what call centers can do and what you can automate with agent, right? Like the literacy has increased, and hence the ability to do transfer knowledge of like, why are we still running our supply chain in the way, we've been doing it for 20 years? Why are we looking at RTLS the way we is now a new point, and that's exciting.
That's cool.
So I get excited.
I get excited.
That is nice. And again, not from just a safety standpoint, but just from a cost standpoint.
Right.
You're driving down I'll go back to safety and resources. If you're not, as a nurse or clinician, not having to make those steps take time to make to the other end of the hospital, right?
Yep.
And so what are you saving in time for saying, one, we've got those resources where they need to be. Someone doesn't have to go search for them, right? And so when you look at this as a whole, what you're doing is an optimization of people and time.
Yep, its productivity gain is massive.
Yeah.
Look, I was in a conversation just this morning where, and I think you all know this, it's this like, old flagship study from McKinsey is like, where do, especially like now nurses and caregivers, where do they spend time? And like it's 25% patient facing, 75% non-patient facing, meaning administrative and now ambient listening, great, takes care of sort of documentation, big item. 4 miles a day is what they walk. McKinsey has its own category called hunting and gathering, which is describing the idea of like, walking around. But horrible, like that, even that is a category name. So we need to go after all of these different items, and we need to reverse that order. And it needs to be 75% patient care and 25%, administrative and non-patient facing activity. And that is what AI is going to do. And we are going to be a small, not the only one, like a small probably contributor to that shift. And I think collectively, and that needs to be the quality standard, I think, for every single technology company and like for ViVE and all these events is, are we going to be there in 4 or 5 years? Because we need to be, because that's the ultimate opportunity that AI offers us. And if we do so, it resolves all the downstream effects. Like right now, right? Like you're going to these striking things, like nurse to patient ratios. Like, well, if we reverse this, we don't have that problem anymore. Labor shortages. Solved.
And you're taking out those friction points that nobody really cares about anyway.
Nobody wants to do them. Nobody's going into that profession saying, I want to spend 75% of my time
tracking down, hunting and gathering
with patient. With patients.
Right.
And you said many times, nurses want to be patient.
they just want to be with the patient and they just want things to work. Like they're not asking for the world. They really
so it
just
needs to be seamless. It needs to be effortless. It doesn't need to be another tool. It doesn't need to be another interface. Like, which is why I'm always also stating internally, like, our objective should be to kill and reduce interface interaction.
Right.
Yeah.
The best interface is no interface.
Yes.
So in order to do that, we need to focus on being seamless execution in the back end. Is it us? No.
Yeah. Yeah. There's ringing in the background.
Not us.
It's not us.
Not
no.
us.
So no, I think that as we talk about, tips, tools, and tricks of what's happening in the hospital around the staff and around the equipment and around all of these things that cost time and money.
Yeah.
Contact.io has found this magic sauce to putting it all in a bubble that works, right?
Yeah.
I don't even know if it's magic sauce. I just think we followed the boring path of saying, what are existing problems that have been broken? Why don't we do it better? It's 2026. It's not 2008.
That's
Take
innovation.
a relook at some of these things, and you're shocked how much little innovation was done.
Yeah.
And if you're just applying, and yes, it's a hard problem because it involves hardware and software and services and now AI. So you really, you need to think about things kind of holistically.
Yeah.
But the opportunity is there because, going back to your experience, everybody said, this is great if this would work.
Yeah.
Nobody said,
Yeah.
this really works. It's seamless. It's great. Yeah. So if you see that, that's the entrepreneurial spirit, right? Like, okay, so let's fix it. Let's do it better. Let's prove it once. Yeah. And then let's do it over and over again. And I think, I want to say probably by the end of this year, we will be with, 40% of the top 20 health systems that have made that switch and that are consolidating their efforts and are moving off some of the legacy technology. Because it's cheaper, it's faster, it's easier, it unlocks them and puts them in the AI era. And that's fun.
For our health systems that might be listening to this segment here, you got 20% of the top health systems out there. What's the barrier to entry into this program with Contact.io? Because again, small rural hospitals, they don't have money and budgeted fund, but they still have the same problems.
Right.
Right.
Correct.
So how do we address the rural hospitals, these facilities that have to provide this patient care?
Right.
They have less, but they still have to do the same amount of more.
Yeah. So I think very first important point is, for us, there are typically 4 to 5 entry use cases.
Okay.
And I'm not going into the details right now, but like staying on the conceptual level.
Yeah.
If you are an academic medical center in New York City, your entry use case is not going to be the same if you're in a rural hospital in
Upstate New York.
Wyoming.
Yeah.
And so what is the same thing, and it always goes back to I think sort of the two principles that drive everything that we do, is what stays the same is the mission of providing the best possible care, measured in clinical outcomes, and that's where nobody can argue. That's the number one objective, and doing that at the best possible cost structure. In other words, not to be in excess spending. And yes, a 40 bed rural hospital doesn't have problems around equipment management as an academic medical center with like 4 or 5 different hospitals in the same division within New York City. And so, and also staff safety might not be the pressing problem, but you will go into different issues around capacity, throughput, access.
Yeah.
And so the team is pretty specialized and has a good understanding. And we'll put it this way: we have not yet found a hospital or a health system where we haven't identified an entry use case that resonates. And that is also, I think, pretty important. If you run on legacy technology, probably 70% of the hospitals that we start interacting with already have had some existing RTLS footprint.
Yeah.
And we come in, we say, oh, great, so you know the pain and you see the vision. Let us make this whole. And we'll start here, and then we take this over, and then we kind of put it all together.
Okay, so let's figure out, for all of those that are listening, how can they find you? If they're here at ViVE, how do they find you? And if they're not here at ViVE, where do they go?
They're here at ViVE, then they can swing by our booth, but I will be heading home because of the storm, and I had to leave early, and so I had to fly back early.
Yeah,
But the easiest way is reach out to Philip at Contact.io. We have offices in New York, further down on the East Coast. Pretty big team all across the U.S.
All
And
right.
I'm always happy to kind of meet new people, health systems, other entrepreneurs. Feel free to reach out anytime.
Yeah.
Right.
We need to pay forward.
That's
That's
right.
right.
100%. Well, you're doing some great work. Great work for our
Well,
nurses.
only at the beginning.
Yeah.
Only at the
Well,
beginning.
you got to start somewhere.
Yeah.
That's right.
Thank you so much.
Philip, thank you very much for coming on to the show today.
Perfect.
It's been a pleasure having you. Hearing about Contact.io. Make sure you find Philip here. If you're at ViVE, make sure you're finding him on the floor. Make sure you, say your last name for the audience so they can find you.
Gilsa, Philip von Gilsa.
Von Gilsa.
Philip von Gilsa. So if you want to find out more about what the newest contactless RTLS looks like, this is the man to give it to you. This is the company to give it to you.
The vision.
Bye-bye.
Thank you,
We're gonna get
Philip. Thank you.
We got our next person coming to the stage here. We've got Leigh Bigler.
Ooh, this is
Now.
exciting.
Leigh, thank you for joining us today.
Oh,
What we're going to do,
thank you.
keep Mike up here. We're going to have a quick conversation here. But we love the name of your company for the obvious reason.
I know.
mean,
Grace reached out, and when we saw this, we were like, oh, well, I don't even know what he does, but he must be on the show. And you're about to learn why.
is there another guy named Mosquito out there?
Right?
Yeah.
Yeah. Well, similar
I
look.
mean, we're getting close. Trust me, my brothers look just
You
like
got
you.
a lot more hair than me.
Leigh, thank you for joining us on the show today.
Thanks for having me.
Yeah, we're excited.
Is this your first ViVE?
This is not my first ViVE. Came a couple years ago.
All right.
So it's good to be back in LA.
Nice.
Nice to be back in
Nice.
LA.
Yeah.
Glad to have you here. Tell us a little bit about your company. Why don't I hear
Sure.
about
Well,
that?
thank you. That's what we're here for, right? So,
Yeah.
well, I represent Buzz Health. Essentially, we provide a API that enables any workflow for a doctor, a patient, or a pharmacist
Okay.
to access affordability and be able to see price transparency for drugs. So we
Wow.
tell exactly what the lowest price is for a patient for a specific medication at any pharmacy.
I need to make sure people
Yes,
understand what
you
you
heard
just
me.
said, right? This man has developed an algorithm that will search the internet any and everywhere for the lowest price.
It's a little more sophisticated than that. We're
Ooh.
not screen scraping.
Yeah.
We actually embed our technology with several other discount card organizations.
Okay.
So a lot of times when EHRs implement with one discount card,
Right.
Yeah.
they're getting price from one discount card.
That's it.
We're an aggregator of many, many discount cards. So we're a one-stop shop. You can come to us, access our API, and we're going to provide you the best price, hands down.
Oh, my
I'm
gosh.
a consumer for me. So
Yeah.
I'm here in California this week. I need to look up something that I need to have on site. Where would I get use of your technology?
So right now we're involved in several workflows. We're starting to work with EHR systems so that when you're a patient meeting with your doctor and they're consulting with you, they're going to ask you, what's the price? About 77% of all providers say that on a weekly basis, they're asked pricing questions about their drug.
Yeah. And they don't know.
Well, they don't, right? That's the problem.
Yeah.
And it's not like the old days when doctors would write it on a piece of paper and say, good luck, and you'd leave, right?
Right.
Patients expect doctors to know what the best rate is. And if they're asked what that rate is and they get something and they go to the pharmacy and it's a different rate, well, now it's a trust issue, right? So we're focused on engaging with the doctor at that point, but the patient themselves can actually go to BuzzRx or rxcompare.com and actually look at the different prices that could be available for the prescription they've been given.
Okay, so what I love about this, there's a lot of things I love about this, but what I really love is it's an immediate connection then with that patient. Because if they say, listen, doc, I can't afford, I just went through this with my own dad. So my dad has stage 4 lung cancer. He had to switch insurance at the beginning of the year. It's just been a big hassle. And a medication that he was taking was helping him greatly. Well, it's no longer covered any longer. And so he said, I can't afford a $1,200 a month medication.
Right.
It was an immediate conversation with that doc. And I love this because it's an opportunity to increase compliance. It's a negotiation over what other options can happen. And it's a reclaiming your own autonomy as a patient then as well.
That's
I
right.
mean, I'm sure you experience some of that when you hear these stories.
Many times. Abandonment rates are way too high in the United States, and most of it has to do with barriers of cost and prices. So we're really trying to cut that down. And I think what's great is in the industry, you're seeing a lot more of this. We just heard about Trump RX, right? Which is wonderful. Trump RX is further educating the patients in the United States as well as providers that pricing options are out there. Now, Trump RX isn't necessarily a new concept. They're just serving it up in a way that's probably more meaningful to patients, which is phenomenal. So we're grateful for those kinds of platforms creating awareness, because as a doctor, when I'm sitting with a patient, you can see that whatever the benefit price is one thing, but the discount rate may be different or better. But if the doctor doesn't know the two, they can't help, right?
Right.
So that's a problem.
Right. That connection is just so magical, though. Okay, so then take us back to, again, tell me a little bit more about the consumer side. So you mentioned that there's a website that you can go to.
There is.
Okay.
You know, we're more of a B2B company now than a
Okay.
B2C.
You better be
B2C.
plugged
That's
in
right.
and keep
Okay.
glasses.
That's
Okay.
right. We do have a consumer brand, which is
Okay.
BuzzRx.
Okay.
And we've got lots of consumers and patients using our application. You download it, you type in your medication, and a coupon will appear. But
Right.
our BuzzRx is just one is just one discount card. It's so sometimes it might be the lowest rate, but not always. And this is why we're connecting to so many other discount cards, because we want to ensure that when we pull that price back and give it to the doctor or the patient, that is the right price
Yeah.
for that drug at that specific pharmacy, because it's a little bit like spaghetti in healthcare, right? So
Right.
if I'm a patient, I get a prescription and I look at a discount card, that price may vary between one pharmacy to the next.
Yes.
Like, who can keep track of all this?
Yeah.
So we're simplifying it. It's all aggregated. It's right there. We ask that health systems, hospital systems, EHRs start to work with Buzz so that they have full price transparency across all these.
It's interesting because I remember I had to pick up a bed once, and I'd been going to my standard pharmacies that I'd been going to, and I pulled my med out in front of a friend, like, oh, how much you pay for yours? Again, friend's like, I
Yeah.
said, how much you pay for yours? Like, I know, it's free. I'm like, where do you go
Right.
that I don't go, that you're getting it for free from that pharmacy and I'm having to pay for it?
Yeah.
Right. But I wouldn't have known unless it was word of mouth. So it's great, again, the awareness and getting the word out. There are options for medications.
There
out
are,
there.
and we're such creatures of habit, right?
Yeah.
You go to your doctor. Where do you want your prescription sent? The pharmacy by my house. Like,
Right.
we're used to that. But now that we actually have visibility into this, we're going to make better shopping decisions.
Yeah.
That's what it's all
Yeah.
about.
Yeah.
I mean, that's right. That's what we do.
I want to know where this all, I mean, I understand the power of what you all are creating and the reason why, but tell me more of the backstory of how this came to be.
Well, as we started providing services for pharmacies on adjudication of discount cards, we saw value in what we did for them, because today, if you just download any discount card app, right?
Yeah.
And you get that discount card and you take it to that pharmacy, the price for that drug might be good for the patient, but it's a bad price for the pharmacy.
Right.
And remember,
Okay.
this is an ecosystem, right?
Yeah.
So we're trying to create a balance that provides the right pricing at the right point for the patient, but also doesn't gouge the pharmacy because they're losing lots of money in the back end. So this really stemmed from us getting more engaged and involved in the workflow of a pharmacy and moving upstream further and further to the consumer,
Yeah.
now to the provider. And now we have complete visibility into the entire ecosystem that provides the best price in any given situation.
Yeah. What's that market response been? What are you hearing? Are you hearing good and bad because you're equalizing the playing field? I would imagine that every good intention has some sort of a bad. Yes. Yeah.
It does.
Yeah.
It does. And you know, I think it's creating and educating people that we're not here to, we're here to you know, what all ships rise with the rising water, right?
Yes,
So
yes.
so there's an opportunity for all of us that are participating in this program to see more prescriptions, to see more of those discount cards being used, because today the reality is an EHR might be working with one discount card. When they submit that to the pharmacy, the pharmacist is going to see it and say, this discount card is not going to be the best price for the patient. They're going to ignore it.
Yeah.
They're just going to apply a different card, right? And so if we can provide the best choice up front, the pharmacy is more likely to use it,
Okay.
which then is going to benefit the EHR because they get revenue share off these,
Yeah.
right? So
Yeah.
that's kind of the way the ecosystem works. That's right. That's right. Trying to level it out.
Again, somebody's getting slighted today, somebody else tomorrow.
Yeah.
Somewhere in
That's
the
right.
middle follows the patient, me.
I'm telling you, at the end of the day, it all comes down to the patient, though. We're an
does.
advocate of the patient. We want them to get the drug. We want them to be on those medications to improve their health.
Yeah. Yeah.
So what's on the horizon for Buzz Health? What's next?
Goodness. Well, next year I'm hoping that we can sit down and I can tell you that all the EHRs are using our API, and that's where our focus is right now.
Nice.
So we would like a little bit of that revenue share.
Yeah, I mean,
We'll talk off.
Yeah. No, that would be awesome, though. I want that growth for you because clearly your product is doing something very impactful in this industry, and it's so tangible. And I love the tangibility of these solutions and the people and the partners. It's really quite lovely. So how do they find you?
Buzzhealth.com.
Okay.
You can find me on LinkedIn, and that's probably the best way if you want to send me a note. I'd love to talk to you.
Laith
Yeah.
Bigler. Thank you.
Yes.
Laith Bigler.
Yes.
Find this man. This man has a gift for you out there.
Yes.
This has been an amazing show today because, again, to bring something to an audience that many people just take for granted. Just sitting to my pharmacy, you're right down the street. But to know that there's now a product on the market that's going to be plugged into EHRs. We all use our portal. We all have it sent to that pharmacy that's in there, right? But for them to now be able to source better costs for our drugs, I think that's truly doing a service to our industry.
It is.
We feel the same.
I mean, this is a big one.
We're very passionate about it. So
Yeah.
thank you for allowing me to come on the show.
Do you have a booth here?
We don't have a booth at ViVE,
Okay.
but we're typically at Health and all the other industry shows. We'll be at HIMSS in a couple weeks.
All right, we'll see you there.
We'll have a booth at HIMSS, so stop by our booth at HIMSS.
Yeah.
Don't have the booth number memorized, but we're there.
Okay.
All right. So you'll be able to find Buzz Health, not Associate Buzz Podcast.
Although it could be in the future.
You never know.
Don't discount that. They're doing some great things in the industry for cost transparency, price transparency around our drugs, making sure you, the consumer, are getting what you need, where you need it for the best price. We want to thank Laith and his group for doing all this hard work in our industry and for coming on this show so that we can bring this to you. Maureen, I mean, you as a nurse, how many drug scripts have you passed to a patient before they walked out?
Oh my gosh, I think almost every single patient leaves with a prize. So
right?
Yeah.
And so these prizes come with a cost. We've got companies like this doing the good work. So we thank you for watching this live episode of the buzzpodcast.net. Maureen and I will be on site all day today shooting episodes and bringing this content to you. So find us if you see us. Maybe we'll get you on the air. But if not, find Laith Bigler and Buzz Health on the floor. And until next time, until our next live show, you keep buzzing.
Thank you.